Orthopedic surgery is a branch of medicine focused on conditions involving the musculoskeletal system, the cartilage, ligaments, tendons, muscles, and connective tissues. And tonight we're excited to discuss how Northwell Health LIJ Valley Stream is the first hospital in America to receive all 5 orthopedic specialty certifications available from the Joint Commission. Even if you might not know what that means, and the guests who are joining me this evening can tell you that's a very big deal. Greetings, I'm Michael Hinman, Executive Editor of Herald Community Newspapers, and your host for yet another fascinating Herald Inside LI webinar. Tonight we're talking about orthopedic innovation. Joining us are Dr. Gil Scuderi. He is the Vice President of the Orthopedic Service Line at Northwell Health. We also have Dr. James Germano. He is the Chair of Orthopedic Surgery at Northwell Health LIJ Valley Stream Hospital, and Dr. Alfred Faust, the Chief of Spine Surgery at Northwell Health LIJ Valley Stream Hospital. So Dr. Scuderi, Dr. Germano, Dr. Faust, good evening. Let's meet each of you. So first, Dr. Scuderi, tell us a little bit about you and your vast experience.
So Mike, I've been in practice, I could say almost for 4 decades at this point, having graduated SUNY Downstate Medical School in Brooklyn, gone on to do my residency at Lenox Hill Hospital in Manhattan, and fellowship at the Hospital for Special Surgery. And my practice focuses on surgery about the knee. Been doing it for years, as well as a major educator in the healthcare system as the fellowship director for adult recon and one of the attending surgeons at the Long Island Jewish Valley Stream.
Wow, that's absolutely fantastic. And Dr. Germano, how about you?
So I'm a Long Island native. I kind of grew up here. Did some training in upstate New York, and then I did all my orthopedic training in Boston and my fellowship in Boston. I decided to come back home where the family was, and I did private practice for about 10 years, specializing in hip and knee replacements, with a real subspecialty in revision surgery. Revisions mean, redoing old surgeries that someone else previously had, usually by other physicians. When things go wrong, I kind of fix them up when they're, or the complicated stuff. After about 10 years, we decided to join Northwell Health. I was getting a little tired of just doing surgery. I wanted to give back a little bit more, do some education, do some research, and really be part of more of like a community hospital where I could work with other doctors and really advance the field of orthopedics. I teamed up with Dr. Scuderi, and together we're doing a lot of good work here, really improving orthopedics, learning a lot of new stuff, doing a bunch of research, and teaching both fellows and residents as they move forward in their careers.
Excellent. So great to hear that. And Dr. Faust, how about you?
Yes, so I'm a full-time spine surgeon. So I finished my formal training back in 2004. So I'm approaching almost 20 years in practice. I did all my training down at Johns Hopkins in Baltimore. And I remember as a resident seeing Dr. Scuderi at a lot of the meetings we would go to, and he doesn't look a day older. So I give him a lot of credit in that regard. I hope I look that good too in time. But so I studied 6 months. I stayed and did my fellowship for a year where I did all my training. So during that year, I focused on hip and knee replacement and spine surgery. So when I got to my first practice, I focused on all of that. So I did a lot of fracture work and things of that kind. But then over time here on Long Island, I've gravitated exclusively to spine. Now it would be rare to do any fracture work if I'm on call. Then I take what I have to deal with. But now, yeah, my practice is exclusively devoted to spine care. And I'd say a small percentage of patients that come in require surgery. So on any given day, there might be a few people that need surgery, but the vast majority have non-operative needs, which I spend plenty of time just evaluating that. And Dr. Germano and I came on board at Orland and Cohen probably about the same time, so maybe 15 years ago. And like James, we moved over to Northwell 5 years ago, and it's been a great relationship ever since. So I'm looking forward to growing more within the Northwell system.
Absolutely fantastic and great stuff. And I agree with you. If I even look half as good, Dr. Scuderi, I mean, I look like I'm 50 years older than you. So it's keeping that look.
I appreciate that, guys.
Still
Well,
look younger than you, Gil, so I'm good.
so, but let's talk. So, Dr. Scary, let me just ask you, since since you were first to come up here, so the five certifications that we talked about that came from the Joint Commission, tell us a little bit about that. What do we mean by that? Like, what are those, and why is that so special?
That's a major recognition for Long Island Jewish Valley Stream. Total hip replacement, total knee replacement, spine surgery, hip fractures, total shoulder and ankle replacement. It just brings to everyone's attention the quality of the work that we do, and that we've achieved the metrics that the Joint Commission, feels are important. And actually, in hip and knee arthroplasty as well as spine, we have advanced accreditation. So we are actually, leaders in the field. And this took a major collaborative effort by all the staff. It's not just the surgeons alone, it's the nursing care, the physical therapists, and all our other ancillary services to have us recognized as quality leaders in orthopedics. And again, we're one of the only hospitals to achieve all five recognitions, in this field. And, it's a major testament to the entire team at the hospital.
Yeah, that's awesome. I mean, and it's so great to hear that. I mean, we don't really get to we see hospitals, we go by them, but we don't always know exactly what's inside, and to be able to hear about things like that, to see where, I mean, these are things that I mean, you had to go through a whole process, right, for this, and to get this recognition.
Yeah, it is a complete process that goes on, and we get reviewed almost on an annual basis with reports, and that puts us above the rest. I mean, and that's really what we want to be known as. We want to be known as leaders in the field of orthopedics, delivering the best quality care, to our patients, and being recognized, by our community is important. And I'm talking about the orthopedic community.
Yeah. So, Dr. Scary, what are some of your most common procedures that you do, in particular? Like, and what does that entail for some of those? Like, what is the most common things that you're doing for the most part?
Yeah, so my practice only focuses on surgery around the knee. So I primarily do total knee replacement, revision surgery. You heard Dr. Germanos, talk about how patients come to us after they've had failed surgery, and complex revision surgery, where patients have had 2 or 3 operations and really are disabled by it. But knee arthritis is one of the most common ailments that patients present with, knee pain. And replacement surgery now at this current state is, with the modern techniques, is a very high rewarding operation. And the revision surgery, very complex, but again, also rewarding for these debilitated patients. And that's the total focus of my practice, nothing else.
So the knee part of that, is that just for like arthritis? Is it so like even younger people who might tear cartilage or things like that, sports injuries, those kind of things, or is it a little bit more focused than that?
So, primarily I'm doing knee arthroplasty, but I do have a subspecialty in, sports injuries with torn cartilage, ligament injuries. That is another component of my practice, but in the more recent years, really focusing on the reconstructive surgery.
And Dr. Germano, I know you kind of have, some similar practice areas there, but you go a little bit further than that too, right? You kind of work a little bit with hips and such as well.
Yeah, correct. So I do specialty in both hip and knee replacement. So like Dr. Scuderi said, very rewarding surgeries, mostly arthritis. Probably 98% of my practice is arthritis or some sort of deformity around the hip or the knee. And I'll do complex surgeries, where it's not uncommon for a patient to see 2 or 3 other surgeons that feel that they can't take care of it, and they send that to me. That's kind of my enjoyment in what I do. I really enjoy the complex stuff, thinking outside the box. So I love working with those patients too. It's very, very rewarding when a patient's seen 3 other surgeons and then they come to you and you're the one that can help them. It's very satisfying as a doctor and for the patient. So those are some of my most rewarding but challenging cases. But yes, I do mostly arthroplasty of the knee and the hip for osteoarthritis and other things that come along. I do some sports stuff like Dr. Scuderi, but that's probably a very small part of my practice.
I know that sometimes, especially with the older community, that, we talk about hip replacements a lot. In fact, that's a lot of people associate that with getting older. And some people, it's kind of scary in a way, but is it really that scary? I mean, because obviously there's a lot of, help that comes from those types of surgeries.
Sure. Hip replacement is probably one of the best, if not the best surgery ever made. And, you know, even Medicare will admit to it. It's probably one of the top surgeries ever designed. And the reason is it not only helps people with their pain, but it gets them back to functioning a normal life. So a lot of surgeries out there may save lives, but don't get the patients functioning. What we do is actually get them back to their normal life. We get people doing the things they want to do in life, you know, anywhere from the golf or tennis court, getting back to work, you know, playing with their kids or grandkids, you know, just being able to do basic things in life that you can't do because your knee or your hip hurts. So it's an extremely rewarding operation. And, you know, with new technologies and new techniques, we've been doing the surgery for a long time. And I've been doing this for 15 years, and patients from 15 years ago today till today are very different patients. We've seen some tremendous advancements in technology all through the field. And it's really been amazing to see patients get up and walk within hours of surgery. You know, where when I first started, most patients spend 3 days in the hospital and then maybe 2 weeks in a rehab. 25% of my patients actually go home within 5 to 6 hours of the surgery.
Wow.
So, you know, we're doing these sometimes the same day procedures, which really make a huge difference for the family and for the patients. They get to sleep in their own beds at night. And then other patients usually stay one night. About 95% of my patients will leave within 24 hours of the surgery. So we've really decreased the pain and difficulty with ambulation and made it much easier for them.
I mean, it's really amazing. I don't know, just in my mind, I just thought like if I had hip, you know, replacement or some of those types of surgeries, that'd be, you know, in the hospital for like 3 months. So that's very fascinating
Yeah,
to know that's not the way it is at
it's
all.
exciting. You know, when you tell a patient that they're going to be walking about an hour and a half after they have their surgery, they kind of look at you with the, you know, the bug eyes, like, whoa, what are you talking about? You know, but when you see them walking in the hallway and, you know, moving back and forth with the therapist and the family there proud, it's very nice. So it's a very rewarding specialty. We're very lucky.
Yeah, that's awesome. And Dr. Faust, and a lot of your specialty is spines. So can you tell us a little bit about, you know, more specific about that, so some of your common procedures and, you know, what those entail?
Yeah, so the breadth of my practice, I think like most spine surgeons, is from the base of the skull, you know, all the way down to the tailbone. We cover that much ground. Having said that, probably 3/4 of the surgery we do is in the lumbar spine, which is the lower back, and then the remainder is in and around the neck. So an important thing worth noting is that spine surgery is surgery on the musculoskeletal system as well. So the spinal column is usually what gets diseased or worn. And in doing so, nerves get pinched, the spinal cord gets compressed. Patients come in with numbness, tingling, or worse, they could have weakness or pain. But regardless, it's not a problem with the spinal cord or the brain or the nerves themselves. If it was a nerve problem, that would be neurology. If there was a spinal cord tumor or brain tumor, that would fall under neurosurgery. You know, but surgery, spine surgery, is really surgery on the musculoskeletal system and the diseases of that which affect neurological functioning. So I think an orthopedic spine surgeon is particularly well poised to do spine surgery compared to our colleagues on the neurosurgical side, because, you know, from day one in orthopedics, we learn to appreciate and respect the biomechanics of moving parts. So this, one of my most common surgeries is to preserve mobility or try to restore it. So if somebody has a worn knee or a hip, Dr. Scuderi or Germano do a total hip or knee replacement. They go into that fully expecting to restore mobility. When we do a cervical or a lumbar artificial disc replacement, we're trying to do the same thing, because if, on the contrary, we do a spinal fusion, we sacrifice motion at that level. And then
Yeah.
the neighboring discs have to compensate for that by working harder. And the fear is that if you fuse a disc, then the other discs will be on an accelerated path toward breaking down. So that's why some patients have sort of a negative connotation of spinal fusion. Now, having said that, spinal fusion is probably only done about 1/3 of the time, at least in my practice. I'd say that another third or more, we do just decompressions, where we're simply taking bone spurs off of nerves. And then the remainder would be fusion surgery, right? So fusion surgery is only done by this spine surgeon if the mobility at that level has been completely lost. So you're not losing further mobility. So when we do spine fusion, the goal is still to get the pressure off the nerve, but sometimes you cannot do that by shaving away overgrown tissue. You have to put a spacer between the vertebrae to spread them apart. So those are the three common areas of surgery that I do. But I would say that as far as disc replacement goes, particularly in the cervical spine, I developed an appreciation for it maybe earlier than some of my colleagues, and that's probably a testament to my orthopedic background. But I'd say that cervical disc replacement, cervical arthroplasty, is the surgery that appeals to me the most. So if I could only do that for the rest of my career, I'd be perfectly satisfied.
Is that like a long procedure? Does that take a long time to do that?
No, there's a little less work to do when you do an artificial disc replacement. The most important part is clearing out whatever bone spurs or disc materials compressing the nerve of the spinal cord. And then the last step of that procedure, you put a device in, same way Dr. Scuderi or Dr. Germano would. You would press fit the implant to rest between the vertebral bones. And then that going forward permits ongoing motion. If you do a fusion, you put a shim in there, and then you usually hold it in place with a plate and some screws. So a disc replacement takes less time to complete than a fusion. And and if you're doing 2 levels, that could be a 30-minute time savings, and that's a big deal
Oh
if you
yeah.
have the airway retracted during that surgery. So that's just a plus of doing that surgery. It's not a reason to do it instead of a fusion, but I think it's brief. It's in my hands, a 1-level disc replacement in the neck is less than an hour. 2 levels, an hour and 15-20 minutes.
Wow.
You
Wow.
go
I
home
mean,
the same day.
actually, that's pretty fast. I mean, I don't know, just imagine these are long hours, but that's fascinating. And, and hearing about some of that technology is really fascinating as well. And Dr. Germano, I know we were talking in the green room, a little bit here ahead of time that you're talking something about robots, and we didn't get a chance to really get, but just, when we think technology, of course we have to think about robots, and we know there's some type of robotic stuff happening, but, tell me a little bit about elaborate more on what we were talking about on that.
So, I think technology really affects a lot of parts of what we do in orthopedics, before surgery, after surgery, a lot of planning, a lot of post-operative care. We're really connected now with apps and monitoring our patients before and after and giving them exercises. So technology is just not in just the operating room. It's through kind of everything that we do in the orthopedic field. But specifically, something that we're using more commonly now is computer-assisted computer navigation and robotic navigation. And what that does is it does give us some advantages over conventional or non-robotic surgery. Basically, we call it conventional. What it does is it allows us to look at the joint ahead of time. So we're getting a CAT scan and it's creating a 3-dimensional image of the patient, and then we're able to use a computer to overlay the implants that we're going to use over that patient's skeleton. So it gives us some understanding of what we're going to see when we get into the operating room before I even, get in there, before I scrub and get all sterile to do the surgery. Once I'm able to do that, I'm able to manipulate it so that I can match that patient's anatomy and hopefully give them a more normal feeling joint. Then once we're in the operating room, the robot actually has the ability to read the patient's leg as it moves. So just like a little cartoon, as I move the patient's leg, the little leg is moving on the computer screen. So I'm able to watch it move and do some measurements to see if I like the way that it matches the patient. Once I like the measurements, I bring in the robotic arm. So it's not like I'm sitting on the side and there's a robot working and I'm having a cup of coffee, I'm actually in there and it's a robotic arm, kind of like the old automobiles when they have the big robotic arms that kind of build the auto. If you ever seen an automobile like line, that's kind of what it is. And then that makes the cuts. It gives us accuracy within about a 0.5 millimeter, which is a little bit better than the human eye. And in doing that, we're able to put the implant exactly where we had planned. Then the robot can actually read the leg, how it moves after we put the implant in to see if it matches with our plan. If that's good, then we put in the final implants and we close, and that's pretty much it. So it gives us a little bit more of a feedback, and I think it's really helpful. Not to say that it's better than doing it conventionally. I think conventional knee replacement and conventional hip replacement are fantastic operations and very successful. For knees, I do 99% robotic. Hips, I only do about 20% robotic because I think the technology is still growing, and the robotic I do is kind of to learn it and to improve. So I think there's still a lot of growth there because it's very new, and we're starting to use AI like every other field in the country, and adding some of that stuff in so that we can really do these analyses intraoperatively in a real time situation, which is really speeding up the way we do our surgeries too. So that's kind of on the forefront too, and we're really excited about adding all that to our practice here.
And speeding it up. So, I mean, obviously speeding up is good because that means you could probably do more of these if depending on, the list of people coming in. But I mean, are there other benefits of speeding that up as well? I know Dr. Faust had mentioned, sometimes, when something affects airwaves and such, but it sounds like you want to kind of go faster in those cases. You don't want it to be longer than necessary, right? Is that where speed usually?
Yes and no, right? Good surgery is never fast. It's done steadily at a steady pace, right? We don't rush through the surgery, but if you know what you're doing and you've made plans and you've thought about it and you kind of thought of everything that can happen before it happens, it runs smoothly, and smooth is fast, right? So lower operating room times means less anesthesia, means less bleeding, less risk of infection, less risk of blood clots. So we try to move pretty steady through. And what I was talking about with the AI and why it can speed up, can make some difficult decisions that we may not be able to make, or even talk to surgeons that are, in Kansas, who do 3 knee replacements a year and may not have the experience of doing 500-600 like Dr. Scuderi and I. So, with the different experience too, I think it's going to really improve the field. But again, it has a little work to do. We're still at the forefront of it.
Yeah, Dr. Scuderi, how about you? How has technology affected you, what you're doing there?
So technology's here, as James said, innovative technology has become a great part of what we do. What also comes into play is implant designs. We have now more personalized fitting implants that have closer increments of size. As Dr. Germano mentioned, as you make your preoperative assessment, your preoperative plan, you want to try to match, the patient's anatomy. Now I've been designing implants for the last few decades, and the implants that we currently have are very different than when I first started doing this almost 40 years ago. So with the newer designs, it's a more personalized fit. When we came out with the gender knee, the female knee, probably 10, 15 years ago, that led to a whole evolution of, fit and feel, because you want an implant that's going to fit that patient well. And that's come into both, hip and knee arthroplasty. But in the world of knee arthroplasty, the improvement in our designs for a better fit to restore the motion and the kinematics, the knee joint, very important. Then our materials have also gotten better. We have more wear resistant parts. Or polyethylene, the plastic bearing, it's usually metal on plastic, or in the hip, ceramic on plastic. These have gotten much better with the longevity of the implants, because if you can reduce wear, you're obviously going to have an implant that, lasts longer. You think that you're going for that replacement, you're hopeful that it'll, last your lifetime, so to speak. And improvements in fixation, we're still using cement, which is an acrylic bond for components, but also cementless implants, where the bone actually grows into the implant. New technology that's there, and especially in knee arthroplasty, that's gaining a great deal of interest. Also, in our perioperative management, and Dr. Germano mentioned it, how we monitor our patients, with apps. We have our patients sign into a portal that helps track them through their clinical pathway from the time they booked their surgery, with reminders to go for their, preoperative testing, check their knee score, how well they're doing before, and then how well they do afterwards. They periodically get an alert. How's your pain level? What pain medication have you taken? So we're able to monitor the patients, and we're now doing rehab at home with more technology. We have home exercise devices, almost like a Peloton, a portacycle, that the patients use following the recovery for their knee replacements. And with Bluetooth technology and Wi-Fi connectivity, I'm able to monitor that patient's, recovery, while they're at home. And then the other last important part is, preparing that patient for surgery with perioperative nutrition. It's amazing that, athletes will train themselves, with the right diet as they prepare for a marathon or some, athletic event. Well, not prepare yourself for surgery. So with some new technology, and we've begun with perioperative nutrition before and after surgery to improve that vim and vigor, as I like to say, to get a better recovery. So there's a lot going on, and it's not as stagnant as you think. There's a lot of dynamics now going on, in the world of arthroplasty, as well as the world of orthopedic surgery, and we've applied that to everyone.
Fantastic. And we actually have a question from the audience for Dr. Germano. So Monica, who's joined us, she says that I may be a hip replacement candidate soon. Can you speak to anterior versus posterior approaches? I've heard better recovery for anterior.
So right off the bat, I think the most important thing is to speak to your surgeon, right? The anterior posterior approach, if you're an anterior surgeon, you do anterior approach surgery better. If you're a posterior surgeon, you do posterior surgery better. I think you want to see what your surgeon does, talk to maybe patients that he's seen or she's seen, and that will determine what the best option for you is. There's pluses and negatives to both approaches. I'm a posterior approach surgeon, so I think posterior approach is better. I think it's a safer operation. My patients do just as well as anterior approach. I'll go head to head anytime. But one of my partners is an anterior approach surgeon, and he says his patients are great, and he does very well. So I don't think it's so much the approach, but actually the skill of the surgeon, where you're having your surgery, the team that's taking care of you before and after. That's what determines whether people do good or not at surgery, not going from the front or the back. So I think we focus on that a lot. First of all, it's all over Google. They love to advertise it. It's a very easy thing to advertise. So like, oh, if I do this surgery, it's going to be so much better than this surgery. But it's not really true. What's really true is that a good surgeon with a good team is going to do a great job and get you moving and walking, regardless of the approach. There are some negatives to the anterior approach that I won't go through, but there definitely are, which is why I don't do it. And there's some positives to the posterior approach and vice versa. So I think the best thing you can do as an individual patient is discuss with your surgeon why he does one surgery and not the other. I think that's a legitimate question. I probably get that, I don't know, like 12 times, 15 times a day when I talk about surgery with patients. So it's a very common thing I ask. And if you have questions, maybe see one anterior surgeon and one posterior surgeon and find out the differences, why they do different ones. Most surgeons that do either one will tell you the other one works great. And as long as you have a good surgeon, you'll be fine.
Excellent. Great answer. Thank you for that, Dr. Germano. Dr. Faust, we actually have a question from the audience for you as well. So Carrie's asking, what are the determining factors for doing a spiral fusion versus disc replacement? So what is the difference in outcomes and length of physical therapy needed between the two?
I mean, there's a lot in that question. But in general, if there's advanced wear and tear, let's say the disc is supposed to be a centimeter tall, but over time it's now a third of that. And as a result of that process, arthritis has built up because there's a disc and there's a facet. They work together to guide the motion in the spine. So if the amount of wear and tear has gone beyond a certain extent, then restoring motion or preserving motion that's going to be affected by the arthritis, can be a problem. So we have to reach a point where we either fully cease motion and do a fusion so that ongoing motion isn't part of the problem. So artificial discs in the lower back and in the neck are used when it appears as if the disc really has potential to move to its full range still. So the arthritis can only be so advanced because once it reaches a certain point, you're then obligated to do a spinal fusion. The recovery probably feels the same to the patient. If you do an artificial disc replacement, I don't restrict mobility. I, in fact, say to the patient, the more you do, the better, because the more mobility earlier will help you restore your ultimate. So it's the same thing when my colleagues do a total knee replacement. You don't just put that patient on ice. You start them in physical therapy probably the night over the following morning. So you're trying to get mobility back. You got to try to get on it. So with artificial disc, there's no restrictions in the patient's range of motion. But with a fusion, it's a different story because you want that disc space to turn into bone. So there's a limit to how much mobility you want. So you intentionally restrict the patient from certain kinds of motion and even certain kinds of medications, which can interfere with the fusion process. So I would say it's a more rapid recovery when you do disc replacement compared to fusion. And there's no upfront limitations from the next day after surgery when you do a disc replacement.
And by the way, so when you talk about the artificial discs, by the way, and I do apologize, you may have said it, and I might have missed it, but like, what is that? Like, is that like a rubber material? Like, what is that made of? Like, what was that look like or feel like?
Yeah, so that's a great question. Over the past decade or two, there's been a number of different designs, like in a lot of areas of orthopedics, but the device that I use is very much like the total knee replacement that Dr. Scuderi and Germano use. There's three components. So there's a metallic component on the vertebral body above, a metallic component on the body below, and then in between it's like a plastic sandwich where the bun is made out of a metal alloy. It's the same metal alloys that we use in hip and knee replacement. And the plastic, it turns out, it's the same exact plastic that we use in the knee replacement. And these three components are advanced in on block, so you put the entire thing in at once, and then the two parts, the two metallic parts, move around. They remove around the piece of plastic in between. Now, there's other devices where it's more of an elastomer, it's like a rubber washer, but those haven't done as well over time. So the device that I use is the one that's proven to me to be the most effective, have the greatest longevity, and it gives us more options intraoperatively. So there's probably about 3 good cervical disc replacements on our market, but the one that I use exclusively is the one that is as I described. It's much like having a very small, it's like an Oreo mini cookie. You know, you got metal, and then the plastic, and then you just clear the space out, and then you advance it in. And the term we use is interference fit. So you tamp it into place, and then it's designed in a way to stay put when you put it in between the vertebral bodies. And a fusion's different. You put in a shim, and then you secure it there with screws and a plate.
Well, excellent. And just to kind of stay along that lines a little bit, Dr. Scuderi, just someone else had asked, and I was actually kind of curious about this as well. That they heard a little bit about surgery, knee surgery involving artificial gel cartilage. You know, is that something that you're using? And what exactly is that?
So, currently there's no artificial gel cartilage that has been approved, for general use. There have been experimental studies with different materials, hydrocels that have been put in joints, nothing that's got FDA clearance. When you talk about gels in the knee, that's also part of our non-operative approach. And many patients that we see who do have an osteoarthritic knee and may not be ready for surgery. And we try to help temporize their symptoms in a non-operative manner, put them on a program. That includes, physical therapy, home exercise, weight loss, anti-inflammatory medications, even Tylenol. And then we have injection therapies. Occasionally you get an acute pain, you get a cortisone injection. But what we also do is gel injections, for those patients. Again, it's not growing new cartilage, but it's helping reduce some of the inflammation, getting the nutrients back. And that's, hyaluronic acid. And there's been always some debate how effective it is. But, in my clinical experience, we do quite a number of gel injections, for our patients, during that non-operative approach. And when they do have a good response, we repeat the injections every 6 months or so. Again, trying to do everything we can to make that patient comfortable so that they can restore their mobility. I always tell the patients, and similar to what we heard Dr. Faust said, mobility is important. It's the old Celebrex commercial. The body in motion stays in motion. You want to keep that patient as active as you can. So there are various things that we try to do before that patient goes to surgery. So to answer the person in the audience, there's no gel inserts that we can put in. Most of the time, a very arthritic knee has malalignment. You see a lot of people walking bow-legged or knock-kneed. If you just put an insert in, that's going to fail quite rapidly. And that's why they ultimately go for a replacement, procedure. But the gels that we do have is viscosupplementation, hyaluronic acid, and there's many proprietary products out there. And we've had some good success with that as a temporizing treatment. Again, not growing cartilage, but helping temporize their symptoms.
That makes sense. And Dr. Germano, someone else was asking, I'm sorry, we're getting some questions from the audience, so thank you all for submitting those. But somebody just noted that their spouse is a patient and is about to have a full knee replacement. And what they're curious about is, are there circumstances under which conventional rather than robotic surgery should be performed for knee replacement?
There are some, I think. If there's a very complex knee, sometimes conventional equipment is more reliable as far as our own experience in using it, because robotic knee surgery has been on a short period of time. So, and certain kinds of implants may be needed in certain kinds of cases if they are very complicated. So it's not just one knee replacement we use for everyone. It's not just different sizes, but there's different styles of knee replacements that we use. They do certain things for ligaments and tendons and bone loss and other things. So, you know, when we start talking about like revisions, like redos, we do a lot of complex types of implants. A lot of times it's we build them, you know, very customizable for the patient on the back table. We need to get the little piece here and a little piece here. We put those together and then another little piece so that we can really customize it for an individual with complexity. And I think in general, in my hands, conventional surgery is a better option in those cases. Again, a robot is a tool, just like you would use, you know, a calculator to do math versus, you know, put a bunch of peas and move them around. You know, it's just a different way of doing the same stuff. I don't think right now we could say that robotic surgery is way better than non-robotic surgery or vice versa. I don't think we can argue that. But again, just like anterior and posterior approach of the hip, it's really what that surgeon is best at doing and what's best in his individual hands or her individual hands that makes the surgery successful. So it really goes back to, again, you know, if you have a plumber come over, he's not going to go in your tool shed and use your tools, right? He's going to use his own tools because that's what he's most custom with. And you hired him because your buddy said, that guy's great. He fixed my plumbing. So you want him to use his stuff. And that's what's going to make you have a great outcome. And again, this is not just knee, hip replacement, spine surgery. It's not just what happens in the operating room that makes your surgery great. It's the experience from, you know, when you first decide to have the surgery with the surgeon and they're getting you ready for preoperatively, whether it's with physical therapy, whether it's nutrition supplies, whether it's maximizing your medical condition and making sure you have a good medical team to make sure that everything is safe for you, to getting you ready for the surgery, at the time of surgery, in the hospital right afterwards, physical therapy team, the nursing team, the intraoperative team. You know, we have teams of people that work with us. It's not just me doing a case when I come in. It's my people. They're with me every day. They know exactly what I do. That's what makes it so smooth and which works well for my patients. And then the post-op care, you know, not just in the hospital, but also the home care that they get. And, you know, being part of Northwell, we all work with Northwell Home Care. So the people at home care know me, they know my patients, they know what I like. And if there's a problem, they send the messages to me and the communication is there. Because we have this huge system, we can really support the patient from the day the surgery is booked until their full recovery. And that's really what makes patients do so well. Yes, we take the credit because we're the surgeons and our name is on the thing, but it's really the team that supports us, that's behind us, that really make our patients do so well. And I think that's why patients do so well when they come out of Long Island Jewish Valley Stream.
Dr.
Mike,
Shimada.
can I
Oh, go
just
ahead.
make a comment about that too? Because really, James has hit on something that's very important. We talk about surgeons and everything that we do. I do want to give a shout out to my nurses on 2W who got the One Award, which is the Nursing Excellence Award. They were the only orthopedic nursing station that got it in the country, and that really acknowledges their professionalism in nursing practice. You know, the exemplary care that they give to our patients, the achievement and quality outcomes, their interdisciplinary work that they do, and their own, you know, professional growth opportunities. So, I mean, they've been recognized, you know, and again, that builds to the team approach that we have at Long Island Jewish Valley Stream. And I really have to give that shout out to our nursing staff because they make us look good when the patients are on the floor. You know, it's the entire team approach.
I swear both of you are like reading my mind because I was just going to start talking a little bit about the fact that, yes, we have the three of you here and you're both fantastic, but, you know, but there's teams around you. There's teams before, pre-op, you know, during the operation, post-op, you know, or post-procedure, or, you know, for instance. And so one of the people who are in our audience this evening, she knows that she's a home care physical therapist and that they have a great relationship with doctors and surgeons. But what she'd like to know is, do you recommend specific post-surgical protocols, or is there like a website that has protocols that you recommend that she and others might be able to use it as part of that home care aspect of it?
So, I'll address that because we do have, within, Northwell, at least in arthroplasty, and I know that Dr. Faust will talk a little bit about, the spine, recovery. We do have, protocols that we like to follow and recommendations. They're a little bit individualized for patients, obviously, on the hip side, whether it's the anterior hip or posterior hip, but also, with knee replacement and revision surgery. We do have certain protocols that we like to follow. The most important is early mobility, getting the patient up, out of bed, and moving about, working on getting their range of motion, getting their strength back, and getting them onto their normal life. But we've really established, clinical guidelines, recommendations, for our patients as they go through recovery. It helps with a little standardization so that we know that the communication between the staff and the physicians, the surgeons, is very similar, less confusion that way. But again, it does have to be individualized for each patient, depending upon what their specific needs or the type of procedure, that they've had.
So, and maybe Dr. Germano, let me jump over to you real quick. So if someone is experiencing discomfort in their knee, and I know Dr. Scott could also answer this as well. But if they're experiencing some discomfort in their knee and they previously had knee replacement surgery, what should they do? Is that something they should be concerned about? Is that something that might be fixable, or is it kind of like, hey, you already took the trip?
No, actually, most knee replacement and hip replacement patients have very minimal pain and function well. If you get a little achy at the end of the day after doing a 10-mile hike, so do I. So, remember when we do a knee replacement or a hip replacement, we're not changing your body, we're just changing the joint surface. So it's not like it makes you 20 years old again. So you may have a little achiness and a little soreness here or there after doing some physical activity. But in general, you should be able to do all your daily activities, all your normal stuff in your life. And, I have I'm sure every surgeon here can tell you the story of one of their patients who's, surfing or, playing volleyball or soccer or running around, ran a marathon, whatever else. So there's always stories like that. But in general, most patients can do things. So if you have a hip or a knee replacement and you're experiencing enough discomfort that you're concerned, you should absolutely get that seen. There's a lot of reasons for having pain with joint replacement after having them, just like any other problem that we have. It's a mechanical thing, just like your car. It doesn't always work perfectly. Things can happen. They can wear out over time. You can get infections, late infections. So there are things. They're very rare, for the millions of joint replacements we do. How common do we see problems? They're very rare, but they do show up because we do so many of them. So I think it is important to see your physician, have it evaluated by either the surgeon who did your surgery or another surgeon who does revision surgeries, like Dr. Scuderi or I, where you come in and explain what's wrong. Some stuff can easily be treated without anything major. A lot of times, a year or two after surgery, I find patients get a little lazy. They're not doing their therapy like they did. They're not doing exercises. Their muscles weaken a little bit. And all of a sudden, they have achiness and soreness. We put them in PT for a month or two, and all of a sudden, they're perfect again. So, sometimes it's little things like that, and sometimes it can be more complicated. People's bodies change and how they react to these implants. So things can loosen up, the implants can fail, there could be other problems. And it is important that it gets checked out, because sometimes if you neglect it for an extended period of time, you make a small problem a big problem. And you don't want to put yourself in that scenario. So I kind of have an open door policy with my patients. Whenever you're having an issue, you just call and we'll see you that week. Just come on in and, we'll do a quick high five. How you been? It's always nice to see people anyway. I love seeing my old patients that have been, I've had a couple of knees, a couple of hips in them. It's fun to talk about their past and what they're up to now. So I love seeing patients like that. And I think it is important that you see your physician if you don't feel like you're doing as well as you should be, at least for your own brain, if not for your knee or your hip.
Absolutely. And Dr. Faust, I'm not sure, and I know when you talked about this, you talked about that there's certain aspects of spinal that, that would also, go to other specialties, right? So, but one thing that we talked about was like pinched nerves. And I know, although I'd be neurological, but what treatment options are available if you have pinched nerves that are causing pain and numbness that are happening like post-spinal surgery, for instance, especially if those nerves might be hidden by implants and such. Is that something you deal with? Is that something that, that you can offer like insight on at all?
Yeah, and it sort of dovetails into the previous question about post-operative mobility. In spine surgery, we really can anticoagulate a patient and protect them from getting a clot in their calf, because that can be deadly. So
Yeah.
because they had surgery around their spinal cord or around the nerve roots, we really can't use medication to thin their blood to protect them from a clot. So that's why early mobility is essential. So that's why I'll usually say just get up and move. And the instructions to our home care nurses, the physical therapists is pretty purposely vague. Just get the patient moving, walking, getting around their home, and minimizing the potential to develop a leg clot. So that's the main reason we want to get our spine patients moving early. And the same applies for joint replacement patients as well. But there's a real advantage to being an ortho-trained spine surgeon, because during the 5 years of residency, where we've come to understand and study disorders of the shoulder, the elbow, the hand, the hip, and the knee. So when we see a patient with spinal disorder, it could manifest not so much as spine pain, but it could be shoulder pain, it could be elbow or arm pain. So an orthopedic spine surgeon has an advantage, in my humble opinion, over a neurosurgery spine surgeon, because their training is very focused on just a certain element. But we get accustomed to dealing with the other conditions that affect the whole musculoskeletal system. And the beauty is, if I think after seeing a patient who believes they have a spinal disorder, I think it's their hip or their knee, I just make a simple referral, to one of my colleagues in the practice. I could send them to Dr. Scuderi, Dr. Germano, whatever the case may be. So, so you do, when you have a pinched nerve, it can manifest not as pain in the spine, but down into the limb. So you just have to get accustomed. We look for patterns. So if patients have had discomfort for a few days, very few patterns form. So it's hard to figure out someone's condition half the time unless there's a real clear-cut pattern of pain. So if patients come in after a week or two, by then it's pretty clear what it could be due to. Sometimes the pinched nerve is from a bone spur, sometimes the pinched nerve is from a disc herniation, and the end goal is to remove whatever it is that's offending the nerve. And if it's a bone spur, you shave it. If it's a disc fragment, you remove it.
Excellent. That's good. And that's great to hear that too. I know that, I'm sure a lot of us never ever want to hear about the COVID pandemic ever again, but it's still, COVID's still out there, and people are still talking about that. So maybe Dr. Scuderi or anybody wants to jump in on this, how has COVID-19, how has that influenced orthopedic procedures and patient care protocols, and how much of that is still in place now? I mean, has something like, has anything changed more longer term now because of that?
Well, obviously, COVID is still here. And what we have noticed is that recently there's been some of our patients that have been canceled because obviously they got flu-like symptoms and tested positive for COVID. But at least the quarantine period has not been as long as it had been, during the pandemic a few years ago. And we've seen the patients not get as ill, from it. So their surgery would not be as delayed. Once they recover, we usually bring them in for their surgical procedures. But what was interesting, and what I think it truly has impacted us, is in our post-operative recovery, where we used to keep patients in the hospital for a few days. Now we're doing more, same-day surgeries. Dr. Germano says we discharge, some patients, that evening to go home, or the following morning. So it shortened the hospital stay. And we also have more, rehab at home programs, where patients are not going to a physical therapist, especially for hip replacements. They're doing their exercise on their own at home, following either an app program where they're getting specific instructions and videos to follow, or they're interacting with their therapist that comes to them. But we're seeing more rapid recovery programs, and that's really, I think, since COVID. So that's definitely made a major change in the recovery patterns. And we're also seeing less patients being discharged to skilled nursing facilities. We like the patients to go home, as the Wizard of Oz, and Dorothy says, there's no place like home. That is actually the best place for you to recover. It's a more familiar environment to you. You are, able to exercise and readapt to the lifestyle that you want after your procedure. So it has made a major change, I think, in our post-operative management more than anything else.
Excellent. You know, and Dr. Faust, you probably run into this like, you know, quite a bit, you know, because of how complicated. I mean, not that simple what Dr. Skinner or Dr. Germano do, but I don't know. I just imagine not being a doctor myself. I just imagine that, you know, anything to do with the spine has to be extremely complex. But, you know, but how do you encourage, you know, patients to educate themselves, to like to empower themselves in making informed decisions without like going too far on that, right? You know, where you're almost like self-diagnosing or self. I mean, you know, how to find that right balance. So, like, how do you encourage that to happen to find that right balance?
So it's a great question. Some patients will come in and apologize up front and say, well, according to Dr. Google, you know, don't hold this against me. And I say, good, I'm glad you're seeking information. So whatever question or concern your search has arisen, let's talk about it. So I tell them the best thing to do is come in to the office, spend time face to face with the surgeon, maybe bring in their spouse, bring in somebody who doesn't trust, you know, surgery or spine surgeons, and then just have it out. Because I tell people they got to feel it in their heart. They'll know it in their gut when they're ready to have surgery. And I think they can only get there by getting to know the person that's given the trust to operate on it. You know, I don't think spine surgery is any more complex, frankly, than any other area of surgery. Um, it, I don't have a particularly special gift to operate around the spine, right? It's. I mean, you just have to be somewhat more cautious, of course, but it's not as complex as most people would think. So what I'll tell people usually right out of the gate is, look, you're not going to get paralyzed on my watch. It's certainly not going to be due to some poor planning or lack of appreciation of what's going on. We're going to come in well rested. We'll be focused. We'll start talking about your surgery the night before. So I just tell patients to come in as often as they need in advance of their surgery to the point where they feel at ease. Yeah, and I don't think you can only do so much online learning. You just have to come in and leave the office, you know, having spoken to the surgeon to make the commitment and take the leap to have surgery, because it takes an awful lot of like bravery to undergo surgery of any kind, right? So I give patients a lot of credit for considering that, you know, and it's really an honor for someone to let us into their lives in that way to perform surgery on them. And then we just tell them, you know, we never betray that trust. So I would say do come in with questions, good ones. There's no bad ones. What I'll say sometimes is get your husband or get your son on the phone. If you want to pipe them into this office visit, they're welcome to do that. I just think the more family members they get talking about the surgery coming up, and maybe even the more doubters, the better, because it just brings out more questions. And then when everybody's on the same page and has the same expectations, and everyone and the outcomes are good, as long as everyone's expectations are in alignment, then the outcomes are typically excellent.
No, that's great. You know, and that's really actually kind of interesting. I always feel like if I were to go to a doctor and then come in because, you know, I did a bunch of research online, I kind of probably go a little overboard as well. And I don't know, I feel like, you know, doctors would want to throw me out the window or something at some point, which, you know, I don't know if that'd be helpful or not, but I could understand that. And Dr. Faust, do you deal like, so we had somebody from the audience, and I don't know if you can, you know, talk about this or not, but I just wanted to throw it out there anyway. But they were kind of a little bit curious about you know, recent improvements in scoliosis surgery and recovery, like using body casts as a recovery. And the reason why they were asking because they have an adult autistic son who has scoliosis since he was very young, and he wouldn't be able to have tolerated like the surgery and the recovery aspects at that time. And you know, has like they said it's a large S curve. I'm not sure what that means, to be honest, but you might. And so I guess you're just kind of curious, you know, about some of the recent improvements in that type of surgery, if you're able to, you know, if you're able to talk.
I'm not able to answer that. I'd certainly be willing to if I could, but that sounds like a neuromuscular curve that you know individuals had for a few decades. And a deformity specialist, right? So at Northwell, we have a couple of docs who are particularly good at deformity correction and management. So Frank Schwab, for instance, he's sort of our go-to, in my opinion, for deformity knowledge. So he or one of his partners, they're in Lenox Hill. So he could answer that question probably better than anybody around. That's the surgical approach. The non-surgical approach, yeah, we may have somebody in our PM&R department, our physiatry department, that can speak to the use of a brace in that setting. The problem with the brace, as I'm sure the family knows, is that it can create issues with skin breakdown and chafing. And yeah, there's a lot of practical limitations to brace wear. And there
Yeah.
always has been, and there probably will be. But maybe as materials improve with a little more elasticity or a little more lycra, maybe they can find something that gives an element of support to help the patient. But yeah, I wish I could say more than that, but I just have had no experience with it.
No. I think that's very, very helpful as well. And I hope that really helps answer their question. And and I know you're gonna be a little bit surprised by this, but we're almost running out of time here. This has been such a great, lively discussion, and so I want to kind of just kick it around this real quickly, Dr. Germano, and for closing, some closing thoughts and such, and maybe that you might want to touch on real quick, but also if you can, in your different specialties as well, as maybe talk about if there's any community outreach or educational programs related to orthopedic, especially with LIJ Valley Stream that you might be able to share as well.
Sure. I think the what you should really get from any kind of something like this is really that the surgeons are there for you to give you information, and a lot of times our assumptions of what things are going to be and what we see on the internet or in movies is not actually the reality of what it is. So if you have an ailment, speak to your doctor. Come in, ask questions. Like Dr. Faust said, it's really important to bring a family member or somebody with you because we never remember everything we hear. So the more people that are there, the more helpful it is. I love when patients come with written questions because then they can just go through their list opposed to just trying to pull stuff out of the air because they're like, oh, I always forget. So I think it's really important to do those things, ask the questions, speak to the surgeon, understand what it is, and then build a relationship. Before surgeons, we were physicians, and physicians take care of the patient, not just do surgery. Sometimes people forget that. I love the physician part of my job. I love the caretaking. I love seeing my patients post-operatively. I love seeing them 2 to 5 years after surgery, when they're back to their lives. I think that's the excitement in my job. So I think that it's really important for you to build that relationship with your physician as you go in. So when you go to your doctor's office, speak to them, be open with them, ask them the questions you have, be willing to go back and forth with them and question their, with what they tell you. A good surgeon is going to love that because they like the back and forth. And like Dr. Faust said, an educated patient is always going to do better because they're going to try to make themselves better. There's nothing worse than a patient who just kind of puts their fingers in their ears, doesn't do anything we say, and then says, why didn't everything work out right? Right? It's a back and forth, we can only do the surgery. Everything else you guys have to do. So it's really important that we have that, relationship and we trust each other and we both work really hard to make them better. As far as outreach, I think that there are occasionally outreach things that we do. I know Dr. Faust could probably talk to it. He recently just did a lecture series about spine surgery and what it entails. And there are some of the other guys doing that. I've done those in the past for a local community, and I think they're always available. And you could probably go through Long Island LIJ Valley Stream website and find some information on that.
Thank you so much, Dr. Germano. How about you, Dr. Faust?
Yeah, so to James's point, this past fall, 2 of the other spine surgeons and I put on a community event. We welcomed in the community. We did a good job of advertising it, and we'll continue to do things of that sort. But I thought I've done something in my office, smaller, less formal. Want to do the same thing at Valley Stream. My goal is to get a conference room and say, these are the surgeries we did this week, and these are the ones we're doing next week. Maybe take patients through the nature of the conditions from which those patients came that we did surgery on, and then just sit there in a conference room and just answer questions as they come up. And I think if we do enough of that, we can get people to come in steadily. And that's what patients want. In the office, things feel rushed. We can only do so much in the limited time we're given in the office to cover all the bases. So I think these community outreach, what we call patient-facing lectures that we give, are really meant to welcome people in. And I've told people, if you're coming, you let me know. We'll tee up your MRI images and we'll go through your case specifically.
Oh, wow.
And I think that'll make a difference. We're all well trained, we're all confident, we all have wonderful staff, and that's true, throughout New York and Long Island. But I don't know of anyone who's really making themselves available the way we're willing to invite people in to learn more.
That's fantastic. Thank you so much, Dr. Faust. Dr. Scuderi.
Yeah, I think you've heard from my colleagues, both James and Al, have clearly said, how caring we are. But we have created, what I term the culture of caring, within Northwell, especially Long Island Jewish, Valley Stream. We do like to reach out to the community, just as you see us doing this evening. We think this is important to help communicate, with all our neighbors. And our neighbors reach pretty far now that we have, the web. And I think that's really important. What I always think is that, patients come in, sometimes they think they know what their problem is. Sometimes they don't. They're a little nervous. They're a little scared. And it's our responsibility to put them at ease, to explain to them what their problem is, what their options are, and then ultimately give them, the best quality of care. And I think what we do at Long Island Jewish Valley Stream has now been recognized as we started this conversation this evening, as we got the awards, for excellence in hip and knee replacement, spine surgery, shoulder surgery, foot and ankle. It means something. To the awards that we've gotten from our nursing care with the one award, it's that caring that we've put out there to the community. And as I just like to, help you, at the end of this, knowing that Long Island Jewish Valley Stream has come a long way and that culture of caring is there. We have a great dedicated staff that is here to help our neighbors in our community.
Absolutely, absolutely fantastic. And thanks again for all of this wonderful information, Dr. Scuderi, Dr. Germano, Dr. Faust, all from Northwell Health LIJ Valley Stream. Thank you so very much. And that is it for us here at Herald Inside LI. For more information on upcoming events and webinars, you can email us at heraldinsideli@liherald.com. That's heraldinsideli@liherald.com. So for Dr. Scuderi, Dr. Germano, Dr. Faust, I'm Michael Hinman. Thank you so much for joining us, and we hope to see you again.